Okay, so we are ready, and we are live on YouTube as well. I think Prof. Christopher Liu has joined us. He is on board. Hello, Prof.
He's not online, I guess.
Hello, I'm here, but I'm having dinner, so I'll just keep quiet.
So happy appetite.
Thank you.
Thank you for joining, Christopher.
Thank you, Dr. Nancy.
Okay, so we can start, I think.
Yeah, I'm ready.
Okay, great. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everybody. Good evening, good afternoon, good morning, wherever you are. And welcome to the first session in this Cornea series to the Wonderland. And I hope that you will enjoy the adventure, especially with our eminent speakers, Dr. Nancy Raqad from Jordan and Professor Christopher Liu from the UK. I'd like to, it's my honor and pleasure to introduce Dr. Nancy Raqad, who will be the speaker today. Dr. Nancy is head of cornea specialty at the Royal Medical Services of Jordan, and she is a pioneer cornea, cataract, and refractive consultant. In addition, she is the founder and leader of Women in Ophthalmology Arabia, TEDx speaker, and listed on, she is an, I think, Arab platform as an influential speaker. In addition, she received a lot of awards regarding her achievements. So welcome, Dr. Nancy. And of course, I'd like to welcome Professor Christopher Liu, who is with us today. It's a great honor and pleasure. Of course, we will learn a lot from him and from Dr. Nancy. So Dr. Nancy, the stage is yours.
Thank you very much, Dr. Mazen. I'm honored and pleased to be on board of this spectacular academic platform. Thank you for the introduction, humbled really. Thank you for the invitation. So we decided to start with a topic that is very important for all ophthalmologists, regardless of the specialty. Although it is in some aspects purely corneal, but at one stage of treating patients, we all face this kind of presentation or disease. So Macbeth, beware of the moving trees of Birnam. What does this have to do with herpes? Let's see. So if anybody has attended the play Macbeth or read the book, he will know that there were three weird sisters or witches who told Macbeth, who's supposedly a female, but disguised as a male to be able to rule the country, that he can never be defeated until the Birnam Wood, which was the forest surrounding his castle, comes walking towards his castle. So Macbeth interprets this to mean that the trees themselves will have to move before he can be overthrown. So he was feeling content, and he was not afraid that he will lose his throne. And he said, that will never be. Who can impress the forest, bid the tree, and fix his earthbound route? And all this was a symbol. It symbolizes that Macbeth is surprised when his castle was attacked, not by an army of walking trees, but by an army of men camouflaging themselves with tree branches cut from Birnam wood. What does this all has to do with cornea and herpes? Let me tell you, it's two things. Herpes attacks and comes in branches, in dendrites, and it looks like trees, exactly like these trees in the picture in the background. And also, it is very, very a wicked or evil virus, because it camouflages itself sometimes in so many disguising presentations that you would underdiagnose it, and then you have to deal with the sequelae of it. So like the woods of Birnam is the herpes virus. Let's go to science now. Before we talk about the clinical scenarios, let's talk microbiology, herpes the virus, and what's the ID card? It's a single-stranded DNA virus, enveloped, of course. And let me just highlight that we're talking about herpes simplex keratitis or herpes simplex virus in this lecture. We're not talking about the zoster, we're not talking about HSV2, although it might come with ocular presentation, but I'm focusing on HSV1, which is the leading cause of infectious corneal blindness, not only in the industrialized world, but also in the world. So how does it work? It comes to the cell. Once it's in contact with the cell, it hijacks it. It gets in control of the nuclear machinery of the cell and starts putting it under its own control and hijacks the nuclear machinery so that it starts transcribing its own genome and also transcripting it into proteins, so producing more viral or small viruses. And this is the active phase of the infection, which is the lytic stage. When the cell is full of viral genomes and viral capsules or capsids, then it swells, and at a certain point it bursts. So not only does the virus hijack the cell, he uses it, abuses it, and then kills it. So you can imagine how wicked it can be. Now, the other thing, if it decides to stop or switch off this genomic transcription at some stage, and you cannot tell which stage that the virus exactly can switch off this genomic machinery and go to be latent or dormant in the sensory autonomic ganglia. It has so many theories about this, but this is beyond the scope of my presentation. So what we'll be talking about today is the transmission, the triggering factors, how does it present, the scenarios that it presents with, what post-herpetic sequelae we might face, including the neurotrophic ulceration, and our treatment options, including the medical and surgical treatment. How it moves around. We all know, we all seen herpetic stomatitis, which is infection around the lips or the mouth, or sometimes the eyelid skin. So any direct touch with mucosa or infected skin of these vesicles can cause transmission. A very important piece of info that once it's infected, once you are infected or once anybody is infected, it can never be eliminated. So it's there and it stays dormant in the nervous system. Now, studies have shown that by age of 80, 90% of the population are seropositive for herpes virus type 1. So most primary infections occur in childhood. We all have seen children with blepharitis and conjunctivitis. And then this becomes dormant and reactivates later, and we'll talk about this shortly. What triggers it? Now, the most important factor or the most important reason for a herpes virus to come back is the genes and also a previous contact with the antigen of the virus. This is the most important reason that the virus comes back again. What brings it up again? Fever, any stress, fever, cold, trauma, UV light, surgery, psychological stress, immune suppression, hormonal changes, menstruation, any kind of stress you can think of can cause the reactivation of the virus. It just takes, it's opportunistic and takes advantage of any light or a glimpse of light at the end of a tunnel. So it's important that you educate your patient. It's important that you tell your patient once he is cured that this is not going to go away forever. It might come about with any of these risk factors so that he can expect it and maneuver around it. Okay, so what are our clinical presentations? Herpes simplex can come in two forms, either a primary disease or a secondary disease. The primary disease is quite straightforward. It's an active infection by the virus, and it usually attacks the surface layer that it gets in contact with, which is usually the skin, the eyelid, the conjunctiva, or the corneal epithelium. So once it bombards the first barrier in the body, it just gets, it infects it. How? As we said, it just hijacks the epithelial genome and just take over it and start transcribing and producing more viruses and shedding it. So what about, I'm gonna focus on the herpetic keratitis. Now, pain is the most striking in these patients. They come with pain, with the redness of the eye, photosensitivity, watering, or decreased vision. But why the pain is most striking in the primary herpetic disease in comparison with the secondary one? Because it's the first time. You can imagine that the nerves of the cornea, which is 100 times more innervated than any other part of the eye, are still virgin, and the virus comes and gets in contact with them and starts to replicate, and then it swells the cells and prepares the cell for swelling. It stretches the nerves and puts some stimulus in the nerves, and that's why it's very painful. So you see children around not being able to open their eyes. They cry sometimes of pain. It's really very sensitive, which is not much that painful in patients with secondary infection. Still going with the epithelial disease, usually the epithelial disease starts as punctate keratitis, but I don't think, or I doubt, most of us have seen the PEE or the punctate keratitis, because they only last for 24 hours. And usually patients, they don't come to the doctor or to the clinic within that time period. It can be misjudged as a dryness, because there won't be vesicles, there won't be staining, there would be just subtle staining, and there would not be much pain. So it takes 24 hours only in order to callus these vessels and then start turning into dendrites, and the dendrites just shaving off the central epithelium where it becomes bare. And at that point, we have an ulceration and an dendritic keratitis that is very pathognomonic of the virus. So at the edge, we have the viral-laden cells that they don't stain because they're still not bare or devoid of epithelium. And in the center, the crater, which is a bare epithelium. Now, how do we treat this? Straightforward. If you leave it, it's self-limiting, because at a certain time, this virus just stops and apoptosis starts, and it stops perpetuating. And, but this might take a long time. It can take up to 17 days in order to go through all this hassle. It's better you just decrease or shorten the disease activity. So what you do, you give topical antiviral agents, which are very effective, and that's in the market, the acyclovir ointment or the canciclovir ointment, and you can use it like up to 5 times a day, and you can see regression or improvement in, from 5 days to 10 days. If you did not have this option, you can debride the cells at the center. You don't go and scrape the base, because there are no viral-laden cells in the middle. It's only the periphery and the bulbs of the dendrites. So you just scrape them to stop and to debulk the viral load. You can give, if you don't have the topical option, you can give the systemic option. We have the oral acyclovir, famciclovir, or valciclovir, but the most effective and less toxic is the acyclovir of all these 3. So we're done with the primary disease, and it's, I'm sure all of us have gone through this, and it's quite straightforward. What about the secondary infection? Now, before we move to the secondary infection, I would like just to highlight or to understand together, how does that happen, or what exactly is the mechanism of reactivation on the cornea of the herpes virus, and this allows us to understand what kind of treatment options we offer to our patients. Now, it is a triad of 3 factors. In some cases, one factor overrides the other. We have either an active viral invasion that comes retrogradely or retroaxonal transport from the ganglia into the cornea, and we have a direct viral invasion. We either have no viral invasion at all, an activation of immune inflammation from a previous antigen exposure, and this is usually a CD4 T cell mediated immune response, or a cytokine inflammatory response, which accompanies the direct viral invasion. So there's always a mixture of all 3 elements when there is reactivation. And this is important in case of a primary herpetic keratitis that happens as a result of reactivation. I'm gonna just explain this shortly. So the secondary forms or the reactivation, we have 4 forms of reactivation. The first form is a recurrent epithelial keratitis, which resembles the primary herpetic keratitis, but with a very little difference that I'm gonna explain shortly. We have the stromal inflammation. We have a stromal inflammation with necrotizing keratitis or ulceration, and we have the endotheliitis. So these are the main forms of secondary reactivation. Now, the recurrent epithelial keratitis looks like, they have dendrites that looks like exactly the primary, with one subtle change that we have an accompanying stromal haze. There would be a haze. You would see that sometimes in children. You see a dendrite, a typical dendrite, but there is an accompanying haze with it. This is not a primary herpes. This is a reactivation with a cytokine inflammatory response that causes a haze that accompanies the dendrite that you have to address, because this will leave a scar. Usually the reactivation happens mostly after 10 years of the primary episode. Very rarely you see it within 2 years, 30% within 5 or 6 years, but most of the reactivation we see it in the elderly because they had an episode of primary herpes when they were young. And as I said, haze is an accompanying stigma. Now let's come to the most important form of reactivation, which is the stromal inflammation. Now, stromal inflammation, as we said, it comes in two forms. One has a better prognosis than the other, and one is more common. Now, the stromal inflammation that has an intact epithelium, and it only comprises a swollen edematous cornea, and only it could be diffuse or it could be segmental. This is a stromal inflammation, which is a CD4 T cell immune-mediated kind of inflammation. And so we see an edematous cornea and haze, photosensitivity, slight redness. It comes as a subtle change. And this is one of the reasons that we underdiagnose herpes as a cause of stromal edema, although it is a very important and very reversible cause. The other kind of stromal keratitis is the stromal necrotic keratitis. Now, the stromal necrotic keratitis can resemble a bacterial infective keratitis. And it also is the result of first invasion of the stroma by direct invasion of the virus, and also reactivation and immune inflammation. So there we have two components. We have the immune inflammation and the direct invasion. That's why it's more virulent. It proceeds to the complications more quickly. The symptoms are severe and exaggerated. And usually we have an epithelial defect that accompanies this kind of inflammation. And the stroma starts as edematous, but then it progresses rapidly into stromal thinning and might go rapidly into perforation if that was not picked up early. And so, as I said, the picture resembles bacterial infective keratitis with a hypopion, and you have to look for signs, history of ulceration or herpetic keratitis in the past. Any KPs you can see in the posterior part of the cornea, any changes on the iris that give you a hint that this is a herpes, especially that if you started an empirical treatment with antibiotics and the patient was getting worse and the cultures were not giving you any hint. Now, the fourth form is the endotheliitis. The endotheliitis used to be called the disciform keratitis, not anymore, because it's not always disciform, and the endotheliitis, usually the reactivation can accompany or can come and hit any layer of the cornea, and one or more layer can be affected at the same time. Endotheliitis is about a direct infection with the virus as well as secondary inflammation, but unlike the secondary necrotizing stromal keratitis, the direct invasion is not as paramount as the secondary inflammation. So the level of the inflammation overrides the direct invasion, unlike the stromal keratitis with necrosis. So we have an inflammatory reaction inside the eye. You see cells, you see KPs, the cornea is edematous, you sometimes see descendant membrane folds, and it's very important to check the intraocular pressure in these patients because there's an element of trabeculitis, and you usually find it to be elevated. It's very important, again, to remember the triad of the herpetic keratouveitis. You have descendant membrane folds, KPs that are subtle, stromal edema, a triad of herpetic keratouveitis that's associated with, look for iris changes, as we said, or it could be only endothelial involvement. And this is one of the very important pictures of herpetic keratouveitis that are missed. They're treated either as uveitis per se, without or missing the causative agent as a herpes, or thinking that this cornea is being decompensated. And a lot of cases are being referred to my clinic in such a picture. And if you look carefully, you would discover that the herpes is the main problem. So this is to summarize this classification of herpetic keratitis, the reactivation form. As we said, we have the epithelial keratitis that comes as a dendritic or geographic. Geographic keratitis is the keratitis that happens, especially if we have a cornea that was treated with steroids from the beginning. So it is an underprivileged cornea, and it makes the dendritic ulceration worse and larger. And we discussed the treatment options. The stromal keratitis without ulceration, which is interstitial keratitis and an immune keratitis. The treatment is topical steroids with oral antiviral. I'm going to discuss that in details shortly, but this is just an overview. Or the stromal keratitis with ulceration, which is called the necrotizing keratitis. We give it oral antiviral in therapeutic dose with a topical steroid, and endothelial keratitis, which was used to be called disciform keratitis. We give oral antiviral with a topical steroid. Now you can see that the stromal keratitis and endothelial keratitis, it's very important to give steroids. Now, if you see the first line, when I say epithelial keratitis or genetic keratitis, and it's very important if there are residents or junior doctors who are attending this, topical steroid is not contraindicated in this kind of epithelial keratitis. But I'm going to go again and explain this shortly. But I don't want them to get mixed up with the use of topical steroids in patients who have a dendritic ulcer. So I'm going to be focusing on this later on in my presentation. So let's talk extensively, how do we treat? If we have a patient who comes with a stromal involvement without an ulceration, steroid is the mainstay of treatment. We don't give a high dose of steroid. It's a topical steroid like prednisolone acetate or Pred 40, let's say 4 times a day under antiviral cover, because although we know that it is an immune reaction, we cannot give it without antiviral cover because the steroid might flare up a reaction. So you give antiviral cover in a therapeutic dose, which is in case of we're using acyclovir, it's 400 milligram twice, or if we're using valcyclovir, we can use 500 milligram twice. Now, if we have a necrotic stromal keratitis, we use therapeutic doses. What is the therapeutic dose of antiviral agent? It is the half the zoster dose, which is 400 by 4 or 400 by 5 milligram of acyclovir. And also we can give, if the epithelium is intact, we can give steroids topically, but in a lesser or less frequent installation than in stromal involvement without laceration. Or you can use a less potent steroid like fluoromethalone or prednisolone acetate 0.1%, because you have to be careful about the epithelium.
Dr. Nancy.
Yeah.
Sorry for interruption. So just for clarification, the therapeutic dose of zoster is 800 by 5?
Yes, this is the zoster dose. We're taking
so we use half. So 400 by 5 or by 4?
4. Yeah.
Okay, great. Thank you.
Okay. Now, we said if the epithelium is breached, which means if we have an epithelial keratitis with dendrites, treat it as an epithelial keratitis first, but keep your steroids aside because you're using it and kicking it in 2-3 days once you curb the infection. Now, I'm going to go back and show some photos of some cases so the picture will be more digestible. Now, in case of endotheliitis or herpetic keratouveitis, we use the therapeutic dose, which is the 400 milligram by 4 or by 5 of acyclovir, along with steroid, which is the mainstay of topical steroid. We're talking about topical steroid in all 3 forms. Now, maintenance is mandatory, and we're talking about 1 year at least of maintaining the patient on antiviral, and to decrease the risk of recurrence to 50%. We can go more than 1 year, and it's absolutely safe, except in few cases that I'm going to discuss. Now, one of the very important things that I would like to say to the patient that, hi, Christopher. One of the things that I'd like to, the patient becomes aware of his condition actually more than the treating physician himself. How is that? The reactivation of a virus, the patient, they start feeling that there's something not right at a certain point. You have to educate them that if there are any stressful triggering event, they have to be careful to pick up signs of reactivation, especially that if you maintain them on maintenance dose, which is 400/2. So any change in any abnormal feeling, any uncomfortable thing they feel in the eye, it does not have to be a direct reactivation with direct infection or inflammation. Sometimes they think that I woke up and I felt something is wrong. This could be the only sign that there will be a flare up. So I tell my patients, especially if there's a weekend or they could not reach the clinic, that always have the acyclovir at home, because if you think that you have decreased the dose and you got something abnormal going on, just take an extra pill or the extra capsule of acyclovir if you could not call us or come to the clinic in a short time. And most of the time, the patient becomes his own doctor. And I have seen mothers who've managed their children reactivation in quite an excellent way. So education is a very important part of treating herpetic keratitis. What about post-herpetic sequelae? What do we see? A lot of us have seen in our clinic a patient who comes just with an opacity and a feeding vessel, or an opacity with an exudation or a crystalline keratopathy or something white that resembles a lipid, and with no clear history at all. Sometimes you have to dig if you know what you're looking for. Ask them about a history of red eye in the past. Don't mention a viral infection or a herpetic keratitis, because they would usually deny that. Ask them if there has been recurrent redness of the eye in the past, and they would admit that. So you would know that they weren't treated for herpetic episodes. And mostly that would happen with stromal keratitis. Now, usually they come with vessels. So the vessels of the herpetic keratitis are segmental. In comparison with other vascularization causes, they cause diffuse vascularization, like burns, atopy, any other kinds of infection. Usually the vessels are diffuse. Herpetic keratitis infections usually are wide bore vessels, and they come segmental. You can have 2 or 3, but they are wide bore vessels. These vessels can lead to opacities by exudating lipids or causing crystalline keratopathy. The treatment options in all presentation is the same. We have to treat the main factor, and we have to treat the sequelae. So to decrease the scarring and the haze, we add steroids at a small potency, which is fluorometholone or prednisolone acetate 0.1%, because we're using this for a long time, and the fluorometholone stays in the cornea for a longer time. And I prefer it in these cases with less effect on the lens and the IOP. The second thing is that we have to close this feeding vessel. Otherwise, no change will be on the opacity. So what we do, we cauterize the vessel. This was in the past, and you have to use an anti-VEGF agent as a subcutaneous treatment or intrastromal in the cornea. So we use Avastin, although it's off-label use, but we use Avastin in my practice as a subconjunctival injection. I can repeat it up to 3-4 times with 1 to 2 months interval between each injection and the other. And I only use 0.1 cc, 0.1 cc to put under the conjunctiva. When in the stroma, I do not give it in the vessel, I give it around the vessel, and it just blocks it, and also bathes the vessel very well, that it blanches, and it's very effective. And you can start seeing the effect in 3 weeks.
Dr. Nancy, may I ask you a question, please?
Yeah, sure, please.
Actually, in the previous slide, I have similar cases, but they are because of mebomitis. So how can we differentiate such presentation from mebomitis-related keratoconjunctivitis? You know, this is an entity related to the mebomitis itself. So especially the flectinular type. So is it the absence of corneal sensation is the indicator, or how can we differentiate?
Okay, there are many factors that we can differentiate between Mebonitis per se or any other causes of a similar picture. History is a very important thing, as we said. Now, Mebonitis does not come as a unilateral isolated phenomena. It comes usually at bilateral. You do not see Mebonitis, you do not see Mebonitis in very old patients or in very young, except if it was due to rosacea. Usually the lead has some telangiectasia, some changes around it that would support the meibomian dysfunction. You would see, if you examine the other eye, you would see an element of dry eye. So that would give you a hint if it's a meibomianitis problem. And usually the history of meibomianitis, it waxes and wanes. So the patient would tell you that sometime I had a history of like chalazion or a sty, or and then usually it does not come with similar picture that the whole cornea is opacified. I don't know if you have seen a whole cornea is opacified in a patient with meibomianitis. Usually it comes with a segmental peripheral corneal opacification because it is associated with the peripheral vascularization that exudates into the cornea, but not centrally. So you wouldn't see a central opacification with a patient who has meibomianitis unless there has been an infection that left a scar in the middle. So the other thing, which is a very important point that Dr. Mazen, you mentioned, is the sensation. Now, sensation is a very important parameter to check in patients that you suspect he has a herpetic keratitis or a herpetic, old herpetic history, but it's not only the cause in such cases. Yani, not all herpetic keratitis patients, they get decreased sensation. And also, not all decreased sensation is caused by herpetic keratitis. And the other thing, herpetic keratitis can cause segmental decreased sensation, not diffuse. We don't, sometimes you might touch or examine one part of the cornea that would be sensitive, while another segment would be aesthetic or hypothesized. And this is because of the herpes. So what's peculiar about herpetic neurotrophic ulceration, let's say, or hyposthesia, is that it can be segmental because it follows the nerves, unlike other causes of hyposthesia that are diffuse. This is one of the very important factors. And another thing that I mentioned, not all herpetic keratitis leads to decreased sensation. If you find the decreased sensation, it supports your theory of this is a herpes. But if you did not find it, this does not mean it wasn't a herpes. So
interesting.
Yeah, so it's a history of previous redness per se, because we had 2 months ago a patient in the clinic who came with merely perforation, a perforated cornea that was plugged by an iris. There was no injection, there was no haze, there was no scar, nothing at all, just a perforation plugged by an iris. And the patient, we tried to, he said, I've never been to a doctor, I've never been sick, never used drops. And then by digging into the history, have your eye been red for quite a time on and off? And he said, it used to be red and then it just goes on its own. And once we gave him the antiviral treatment, it just turned out so beautifully. So we have to be very careful in this regard. Herpes can really camouflage itself in many pictures. Should I go on?
Yeah, please. Thank you very much.
This is one of the patients who presented to our clinic. And as you can see, we have a haze in the center, a hole in the middle, an iris plugging it, a conjunctiva that is injected, and there's watering, as you can see, and the tear film. So what would you do with such a patient? It's very important in these cases to prioritize our management plan. So we ask, if we did not know or the patient did not commit of a previous herpetic history, or he is on antiviral medication at all, it's very important to dig that in the history, as we said. Now, the first thing we have to do is to kill the virus that's causing this. So kill the virus by giving a therapeutic dose of antiviral medication, which is acyclovir 400 milligram 4 times or 5 times a day. So we just give a very high load. I did not have to go into 800 milligram by 4 or 5. Yani, all of the patients that I had to bombard them with a high viral antiviral load, they went okay or very well with the 400 by 4. The second thing we have to do is seal the hole. So would I put something on it from the beginning? I would not. Why? Because we have two scenarios. We either have a perforation that is in the middle of a cornea that is strong and viable, or a perforation in the middle of a cornea that is fluffy and cheese wiring and just melting. So if it's melting, you cannot seal the hole. You just you have to treat, encourage reepithelialization, make it stronger, and then you can seal it. We can just cover it with a bandage contact lens until it regains some stamina. If it is in the middle of a cornea that's strong enough and to withstand any closure, then I would go ahead and close it. If it's 2 millimeters or less, I would put a glue, otherwise a lamellar graft. But I have to make sure that there's no hypopion and there's no concomitant infection with it. So I admit such a patient, I give him IV antibiotics, because the chance of a secondary infection in these cases, I don't know how long the eye has been open like this, is high. So I just run ahead of time. In order to decrease the leak through the hole, I give anti-glaucoma medications or drops, and I use timolol in these cases, which is my favorite. Try to avoid anti-glaucoma medications or drops that would increase the inflammation, such as Xalatan, which is prostaglandin analog, or the acetozolamide drops, because they will break the blood aqueous barrier and they will enhance the inflammation, and they will make things worse. So abide from these drops. Use the simple, unless there's a contraindication, which is a beta blocker. And as you draw the aqueous away from the hole, believe me, the reepithelialization will take place quickly. One of the patients that was admitted and he was listed for surgery for closure of the perforation in 48 hours. On the day of the surgery, he did not need to do a lamellar keratoplasty because the hole just sealed. And it was helped by, I think, the doxycycline that we gave, anticollagenase, and all the other things that we've given him. And this is where I say give some hints. We give vitamin C, doxycycline, which is an anticollagenase and helps the reformation of the tissue of the cornea. Now, the very important question that people might ask is, what is the role of steroids in such cases? Now, this is a cornea that looks like a stromal keratitis with necrotizing. That's why it perforated. So would I kick in some steroids? The answer is you can, but you have to make sure that the cornea is not melting, the infection is not active. If you stain it, there is no active ulceration. You have already kicked in a high dose or high dose of antiviral, and then you can just help it by giving a few drops of a very weak steroid just to curb the inflammation, not at the beginning, a few days after the control of the infection, because you have to treat the inflammatory element of this disease. Want to add anything else before I jump to the other case? Okay. So
Christopher, do you have any comment?
Do you want to say something?
No, I think everything is going very, very well, and Dr. Nancy explaining everything very clearly and very completely and comprehensively. Thank you.
Mm-hmm. Thank you.
This patient I've seen last week in the clinic. He's been around more than a month being treated for herpetic keratitis. And yes, he is a herpetic keratitis patient. But when his treating ophthalmologist, he called me and he said, I've done everything and I don't know how far I can go with doing anything else. Would you mind taking a look? So when he came in, I was just happy because I knew we need something like that to present in this presentation. Now, this is a patient with, you can see there's a epithelial defect in the middle, a cornea that is edematous. In the back, you can see some KPs. The iris, it is dilated, obviously. His IOP was high, and the cornea was also dry. So he has a bit of everything. he reached a stage of a neurotrophic ulceration, and this is the defect that you can see. And the infection has reached the endothelium. That's why we see KPs. We couldn't see if there were cells or not, but we could see that there was an element of inflammatory membrane back. If you can see here, there's an inflammatory membrane going on behind the iris. So the inflammation is going in the eye, and the IOP was high. Now, the question was, if this is an inflammation, shall I give a steroid? And what about the epithelial defect that's large and in front of my eyes? Can I kick in any steroids, or shall I treat the virus? But he's already been treated for the virus for a month and nothing is happening. So what shall I do? Again, we say it's important to prioritize. So prioritizing means we have to kill the virus by giving oral antiviral medication, acyclovir, 400/4, because this is an active infection. We have to decrease the inflammation. Yes, we give in steroids, even though we have an ulcer or an epithelial defect on the surface. Because if we did not curb the inflammation, we wouldn't go anywhere from that point. So I kill the virus with an antiviral medication. I decrease the inflammation with topical steroids. And I also help the surface recover by decreasing any surface agents causing this neurotrophic ulceration. I minimize any drops. I stop most of the medications. I stop even the antiviral ointment because it is toxic at some point. I use only preservative-free lubrications. I also give in something to enhance epithelialization, which is doxycycline, anticollagenase, vitamin C, to increase the chances of reepithelialization. And again, this is not my main concern at the moment. The neurotrophic ulceration will go on for a long time. I have to treat what's going on inside the eye. So the antiviral and the anti-inflammatory, which is the steroid, is the main factors. I won't decrease the pain by giving a cycloplegic, and I would cover the surface meanwhile by putting a contact lens. No need for something else now. I wouldn't use autologous serum for the time being. I wouldn't use an amniotic membrane for the time being, and I will discuss this later on in my discussion. Now, this patient also, he had anti-glaucoma drops, which were both the azopt, acetazolamide, and the prostaglandin analog, the exalatan drops, and they both cause worsening of the inflammation. So first, they cause worsening of the inflammation, and second, they also interfere with the neurotrophic ulceration. So they had to be stopped immediately, and I gave him only the beta blocker to decrease his pressure. One of the arguments with the fellows was, do we need to give anti-glaucoma medications? Now, if the patient inflammation and trabeculitis were controlled on the antiviral and the steroids, the pressure will go down. If he did not reach a level of scarring in the trabeculum and it only was inflammation, so controlling the infective inflammatory process would bring the pressure down. Otherwise, if scarring is there, if the virus left a scar, we would have to retreat to the anti-glaucoma medications. How safe is the antiviral medication that we give? It's very safe, actually. We only don't use it in pregnancy or if the patient has impaired kidneys. It's very safe to the extent that you only need to do a kidney function test after 6 months. If the patient is have immune suppression, also it's not advisable to use because acyclovir and other kinds of antiviral, they cause an element of immune suppression. Very rarely it is reported that it causes thrombocytopenic purpura with decreased platelets. So it's important to do a platelet profile once he comes for a checkup every 3 months or 6 months. And if he is sensitive or hypersensitive to the medication, this will show only in the first 48, 72 hours. So if he's hypersensitive, you just stop it and think of something else. Let's go back to neurotrophic ulceration that we've discussed shortly now. Why does...
Dr.
Yeah.
Nancy, sorry. So let's assume that we have a pregnant patient.
Yeah.
How do you treat them?
I've had that. So a pregnant patient who is used to have antiviral medication, which is oral, and was maintained on it, but she developed a recurrence while she is pregnant. You never give her a systemic antiviral because it is toxic to the fetus. So you stop it. I manage with the topical in very, very sparse or very careful quantities. Now, if she sustained an epithelial disease, I wouldn't use the antiviral. I just debride and give her as just lubrication and wait for it to go away. If she had a stromal inflammation, which needs steroids, I give her steroids. And the antiviral cover would be a topical agent like the topical acyclovir ointment. But I do something that I tell the patient, once you put the ointment on, leave it for an hour and then wash your eye with artificial tears so that the ointment does not stay long on the surface of the cornea and does not cause systemic absorption, no matter how trivial it might be. So we just use it, put the topical drops in. Yeah.
Yeah. The same treatment, can we say, in the first case, perforated if the patient is pregnant? We avoid the acyclovir, of course, orally, but any additional things, topical, just topical antiviral, and that's it?
Yes. We avoid the doxycycline, unfortunately. We've never seen a pregnant lady come with such a picture of necrotizing picture. And I think the hormonal state just protects it from such a picture. We wouldn't see it in pregnant ladies unless the necrotizing inflammation would be so severe that, and there was a trauma or something, sometimes a scratch would just bring this over. I would do a pressure lowering agent. I would do a topical treatment. Yes, I would. I would do a contact lens and take her to surgery in a faster way rather than an older man or an older patient.
Any role for the amniotic membrane in such cases?
Yes, not in the active infection. It has a role in the neurotrophic ulceration, so which I'm going to talk about now. Now, herpes, if it goes on for a long time, it causes neurotrophic ulcer. What is a neurotrophic ulcer? It's an ulcer that comes around because the cornea loses its sensation. The question is why or how corneal innervation play a role in the formation of an ulcer. And the question is very simple and direct, that the corneal innervation and the transmitters in the cornea are very important for the epithelialization process of any ulcer or defect in the cornea. Once that is gone, the cornea the neurotransmitters that are responsible for building or regenerating the layers would just stop transmitting signals for the body to do that. So it becomes hypostatic or anesthetic because of the nerve damage. As I said, it could be segmental diffuse, and this is how we differentiate it from other causes of hyposthesia. And what related factors that would bring this again over or to the surface is dryness, if you have dryness. If you have a lot of drops with toxicity that on the surface, it just gives up and stays bare, and it will damage the basement membrane under the epithelium, so there will be no regeneration. So it's important. Sometimes we say on the skin, if you keep just picking up on a wound that's crusted, you will reach a stage that will not close ever again. And this is the same thing. If you just keep bombarding the cornea with a lot of agents, it will reach a state that it will give up and it will not re-epithelialize again. And I think this happens sometimes with some of our colleagues who have an epithelial defect and they keep scraping it and debriding it again and again and again and bombarding it with a lot of topical medication. They reach a stage or a level that the cornea will not heal back again. So my advice for them is that you try to de-epithelialize the unhealthy margin once or twice, just to give way to the healthy innervated epithelial cells to kick in. Try to decrease any ointments. I don't like ointments in the case of an ulceration, except if we have active epithelial keratitis, because ointments exert physical barrier to the palisading cells that would bridge an ulceration. Use preservative-free drops, whatever they are, bring them from wherever you can. So they're very important to maintain a healthy surface. If you want to put anything in the cornea, try to do it systemically rather than locally or topically, and give the eye a template for growth, which means like give it a contact lens, If it's healthy and there's no infection, give it an amniotic membrane or autologous serum because it has a growth factor in it. If you have an infection, never give autologous serum because you're just allowing the organisms or the microbes to just perpetuate. So you're just kind of feeding them. So never give autologous serum to a patient who has an active infection. If he has a non-healing ulceration, you can because of the growth factors in them. You can use an amniotic membrane, which is a scaffold for regeneration of the epithelium with all the matrix, the collagen, and the anti-fibrosis stuff it has in it. So this is the role of the amniotic membrane. The amniotic membrane is not a tissue that offers replacement of epithelial cells. It's only a scaffold for epithelial cells to grow onto. And also it's a helper. It decreases the inflammation. It decreases the risk of scarring and because it has an antifibrotic effect. And also it provides growth factors for whatever cells we have around in order to bridge the gap and rehabilitate the surface. Otherwise, we can just use, if all these measures, they fail, let me just move to the other slide. We can do, okay, now, if we're talking about how we address HSV neurotrophic ulceration, I usually divide them into stages. The stage one is just starting to come up to the surface, and usually I decrease the drops that the patient takes, and I go to surface lubrication with preservative-free drops. If we had a picture like this eye, where we have a bare epithelium, I said we do a BCL, bandage contact lens, sometimes Botox in order to close the eyelid, might do a tarsorrhaphy. We want just to close the eye to allow a surface covering the surface of the cornea. Amniotic membrane graft, as we said, and it's important to add antibiotic drops at this stage, which are preservative-free, because a bare epithelium does not have a barrier to any opportunistic bacterial infection that would come and infect the stroma of the eye, which is bare now without Decimus membrane. We send aids like vitamin C and doxycycline, as I said, and we help the cornea at this stage. When do we go to a more aggressive treatment option? Is that when we reach a stage 3, which is impending perforation or an eye that's not responding to any of the treatment, a neurotrophic ulcer that's really very bad and very thin. So as if the perforation was small, we seal it with a glue. Otherwise, we do a lamellar graft and we support it with all the medication that we use to support it with.
Dr. Nancy, is there any role for the topical? There is a gel, I think it is Riccio gel by Bush and Lomb, which is, I think, vitamin B, something like this. So does it have any role in such cases?
Neurotrophic ulceration, we mean, yeah?
Yeah.
Now, if it has a substance P or vitamin B, anything that helps the healing mechanism of the cornea is an add-on, which we prefer. But I have some limits in using the gels or ointments on an eye that has a bare epithelium, because I think there's a barrier to palisading cells that bridge the gap. I would like to use it as a drop. So I would thin it in order to make use of the material that is in it, which is vitamin B and a substance B. It's very important for the healing. Yes, it is. But I would rather, maybe this is a message to Bush and Lomb, to make it in a drop rather than a gel-like form. Now, the important thing about gel is because it stays on the eye for a longer time, but it does exert a mechanical or heavy load on the cells, which are very, very light, and they need just a medium to perpetuate and bridge the gap. So I'd rather it be a drop rather than a gel. That's
of course, I have no financial interest. I just received some samples in the clinic, and they claim actually that it helps. So this is why I asked, but no financial interest.
Yeah, if it has this vitamin B and the substance B, yes, it does help very much, actually. And this is one of the things that are important. I did not mention here because I thought this is too advanced. But yeah, substance P is very important for the management of non-healing or persistent epithelial defects. It's not available worldwide, so I'm just kind of keep it a little bit behind the stage.
Yeah.
Yeah.
Okay, thank you.
Christopher, do you want to say anything before I move?
Yeah, so I think, as you say, you can do a tassorrhaphy, which could be a temporary tassorrhaphy in very severe cases, which wouldn't heal. And it would be temporary, so there's no need to bare the lid margins, and generally just one loop of suture, and generally just in the center. So the either side, medially and temporally, you can still open it to, and the patient can be asked to move the cornea from side to side, and you can still examine the cornea, and you can still apply your medications as necessary. And I think even with the very, very difficult ones, with the temporary central tassorrhaphy, they usually heal within a small number of weeks, maybe 2 or 3 weeks, and it will close. Then the question is whether when you reopen it, whether it might break down again. The second point is I have less difficulty with using ointments or gel than you, Dr. Nancy. I think from one of my old teachers, he's still alive, his name is Roger Buckley. He's always explained to me that if you put ointments on, it's not going to stop the epithelium growing underneath it. And the advancing epithelium would never trap ointments. It always goes directly onto the stromal bed and then and will heal. So I think that's one point that we differ in our opinion in the use of ointments for epithelial defects, including such indolent ulcers. Thank you.
Thank you, Christopher. Now, here I would like to add something, or maybe just a question, because I'm learning from both of you. Now, I found a difference actually between the acyclovir as an ointment and Virgan as a gel. I found that the valsiclovir is less toxic. People are more yeah, exactly, the Virgan, I mean, it is less toxic and people are more comfortable with in comparison with the acyclovir. And it is a gel, thin gel. So what is your comment about this?
Yeah, actually, the only available antiviral topical medication is the acyclovir in our country. Valcyclovir or ganciclovir is not available. This is an interesting feedback. I rarely use the ointment, as I said, only in primary epithelial disease, and it just goes away in like 5 to 10 days, so I don't have a problem with it. And I don't rely on it when it is stromal. I only rely on the oral part because, yes, after 2 weeks of using it, the cornea starts to change, and I'm always worried about this change, so I just stop it. So yeah, you might be right. We don't have it here in Jordan, and I would love to start using it if the manufacturer can bring it in, actually. So yeah, you are right.
Christopher.
Yeah.
Thank you, Nancy.
So,
Christopher, yeah, what do you think?
Yeah, well, in the UK, going back 20, 30 years, we've had a number of different antivirals and going back to trifluorothymidine as well. But a small number of years ago, acyclovir ointments became not available in our country. So we switched wholeheartedly to ganciclovir gel. Actually, even though it's more like a gel, technically they call it gutty. So it's an eye drop. And it is true that patients do prefer that because it's aqueous based. It doesn't smear and it doesn't blur the vision quite so much. And we're using that now. So for epithelial disease and also for endothelial disease as well. When there's disciform keratitis, we will use that in combination with steroid and then taper that off. But I think with stromal disease, often we will use oral acyclovir, and that would be 400 milligrams up to 5 times a day, and then tape it off together with the necessary steroid. Yeah, that's it. And it is true that when we were using acyclovir ointments, if you do use that for a prolonged period, there will be damage to epithelium. And similarly, with chloramphenicol, sometimes patients on chloramphenicol ointments, they stay on for too long, and there's very coarse punctate erosions, which then recover once the medication is stopped.
Thank you. Thank you very much for the input.
Shall we move?
Okay, Dr. Nancy, yes, thank you.
Okay, now a very important question that comes along from colleagues and all around: when to operate on a patient who had an episode or episodes of herpetic keratitis. Are there any recommendations that are customizable to any kind of procedure or not? Or would we operate at all if he had this history of herpetic keratitis? Now, the answer is depends on your surgery. We operate, but there are certain measures that we take in order to minimize the risk of flare-up. Surgery per se, it's a triggering factor for reactivation. So we have to minimize this. And what I say when my patient steps into the clinic is that you have to be at least 3 months of flare-up free in order to discuss the surgical option. And I have to see you every month to make sure that you did not flare up. Of course, I would be giving him a maintenance dose of 400 by 2 milligram of acyclovir during all this period. Now, depends on the surgical procedure that I would do. Let's say phaco, if a patient needs a phacoemulsification or an implantation of an ICL, 3 months is a good window to decrease the risk of reactivation and to make sure that he is under the virus is under control. Before the surgery, 3 days before the surgery, or 4 days before the surgery, what I would do, I increase the dose to a high dose of 400 milligram by 4 or by 5. And on the day of the procedure and 2-3 days afterwards. So perioperatively, I would boost him with a high dose of antiviral, and I take it onwards after that, according to the procedure, if it was complicated or not, if it was long or not, if it was smooth or not, if the patient is happy. So I just taper and put him back on the maintenance dose. When we talk about something like the PTK or the PRK, I go with a window of 6 months. 3 months can cause so easily a flare-up, so I'm not at all, and it's not an emergency. I would not go less than 6 months of flare-up free and under control, and I also do a perioperative booster increase boost of the antiviral medication to make sure that he is loaded with the antiviral before or just in case he would kick in a flare-up. And the last thing is that if I'm doing a penetrating keratoplasty, a lot of these patients, they would need a penetrating keratoplasty. It might be a visual because of a scar or a therapeutic because there was a perforation. And it differs actually. So if it's a visual and there was a scarring, it's very important to address the things that are around the cornea. These patients might have vascularization that I would have to treat. I would optimize the corneal surface as much as I can. I would decrease the vessels by anti-VEGF subconjunctival injections. I would cauterize the vessels. I would give intrastromal injections. And on the day of surgery of the PKP, I would refine away from the limbus, because I would be away from the blood vessels as much as I can, or from the, so I would make the size of the graft smaller a little bit, not very small, but smaller than the usual one that I would do, and load the patient. In every case, I would load the patient with antiviral and maintain him for a longer time, because any patient who's undergoing a graft, he's taking steroids at a high dose, for a longer time, so he would be loaded to a longer time. And he would be observed more frequently. Also, if he is in a therapeutic stage and he's been treated but not doing very well, and we had to just remove the cornea and put a therapeutic PK, then we would keep him on antiviral medication and also load him with for a longer time, in addition to the antibiotic drops. And not to forget that I would not bombard him with a high dose of steroids post-graft, especially if I'm dealing with a therapeutic graft. In a visual graft, no, I would, because the risk of rejection is high. I would give him anti-rejection medication like Neural, which is cyclosporin, which medication systemically, and also make sure that he is prepared psychologically for any risk of rejection, because these patients usually the risk of rejection in them is higher than patients with keratoconus, for example. And let me show you. Okay, yeah, this is the corneal transplantation of one of the patients. As you can see, this large blood vessel, we've given him 3 shots of subconjunctival Avastin before it regressed, and we could just treat, get away with the trephination of this opacity. When I trephine, I try not to take out the whole opacity, that especially that's near the limbus on nasally, because it's very near the blood vessels. I would not go that way, in that place. I just try to be in the middle and to clear the central part of the cornea. As we said, I would address the vessel and boost the antiviral dose. And because we expect rejection, we would just bombard him with anti-rejection medication and make sure that if anything happens or he feels uncomfortable at any time, he comes back quite quickly. We keep him on a maintenance dose for long. And as we said, this is safe, and educate him about any triggers of that might fail his graft.
Dr. Nancy, okay, great. So would you please go back to the previous slide? Let's assume that the patient is going to have PRK.
Yeah.
So as you mentioned, at least 3 months.
4 months.
No active.
6 months.
Sorry.
6 months for PTK and PRK, yeah.
Okay. And let's say, when do you start the maintenance dose? Let's say only 4 days before the PRK, as I understood, or more than this?
These patients usually who have an episode of herpetic keratitis should be on a maintenance dose for a long time. When they come to my clinic, they already should be on a maintenance dose. If they haven't been started already, I would start them on the maintenance dose from the moment I see them, and I review them every month for 3 months at least. If I'm PRK or PTK, I review them for 6 months, and I make sure that they are flare-up free. Let's suppose the first month and the second month they were okay. The third month they developed a flare-up. So what I do is I treat the flare-up, and I start counting 6 months from that date onwards. So as if the previous 2 months they don't count. So we have a new date for the counting of 6 months. And I do the same. I treat him or treat her, and then go back to the maintenance dose and see them every month to make sure there's no flare-up. On the day of the surgery, once everything is fine and scarred and everything is quiet, on the day of surgery, I load them with a high dose of antiviral, because surgery is a risk. So in order to minimize the risk of flare-up due to my surgery or due to the laser, I would boost them with a high dose of antiviral medication for a week until I make sure that everything is fine and they pass that period of stress.
And then they will go back to the maintenance dose again.
Yes, if everything is fine and the surgery is smooth and there were no delayed fertilization sometimes happens, a redo, a touch-up, whatever, I would go only for 1 week and then go back to the maintenance. If I find that the patient is still, there was a delay in his fertilization, no, I would keep him for a longer time, and I follow him like every week until I make sure that everything is fine and quiet, and then I would go to the maintenance dose.
Okay, great. Yeah, please go on.
I think that's about it. Yeah.
Yeah.
That's about it. This is only a tribute.
Fantastic. Fantastic. So let's go for some questions. All right. Is cyclosporine an alternative to steroids, or let's say anti-inflammatory, including the cyclosporine or the lifitegrast? Can we consider them an alternative to steroids, or do they have any role in the treatment of such cases?
Cyclosporine per se, topical, yes, it does have a role, but it is not a substitute for the steroids. It's indeed suppressing the immune response, but it does not curb the inflammatory response. So if we think that the patient is not doing very well on a steroid dose, and we need something stronger to kick in or to aid it, we add the topical cyclosporine, but it's not a solo agent. This is the first thing. The second thing, which is very, very important, thank you for this question, is the non-steroidal anti-inflammatory. They are absolutely contraindicated in such cases. Never give a patient with herpetic eye disease a non-steroidal anti-inflammatory. Never give a patient with an ulceration a non-steroidal anti-inflammatory. Never give a patient who has a neurotrophic ulceration a non-steroidal anti-inflammatory. You will be just dooming the cornea for damage forever. So it's a silent killer for me. It's a silent killer for the patient. They would come with a perforation without knowing it. The eye would be numbed and the picture is very ugly. And even when you try to operate on an eye that was molten because of a non-steroidal anti-inflammatory use, and unfortunately it is on the market and being over the counter disputed, it is very, very difficult to stitch such a graft or a cornea because it cheese wires and it melts and it's very bad to control. So never think of it in such cases, no.
Perfect. Does the dose of the oral antiviral, let's say, differ between stromal keratitis and endothelialitis?
Yeah. In stromal keratitis that has no epithelial defect, which means that stromal keratitis only due to an immune-mediated T cell response or CD4 T cell response, the dose is only a prophylactic dose, which means 400, like the maintenance dose, 400 milligrams twice daily, along with antiviral cover, because it's a subtle inflammation usually. Now, as we said, sometimes there's a combination of herpetic keratitis picture in the same eye, which means that I might see stromal keratitis with an intact epithelium and some KPs in the endothelium, which means there's an element of active invasion in the endothelium. So which way I go? We go with the worst scenario. So top up your antiviral dose, because if it's endotheliitis, I would give anti-inflammatory drops, which is like Pret 40 by 4, if the epithelium is intact, we're talking. And I would give the therapeutic dose, which is 400 by 4, 400 by 5, acyclovir. Rather than, if the endothelium is very quiet, there are no KPs, no descendant membrane folds, and no changes in the iris that would tell me that the virus has gone through this eye, and it's only confined to the stroma, I would give it only a therapeutic dose, 400 by 2, with a topical steroid cover, Pret 40.
Perfect, thank you. There is a question of one of the attendees. Any experience of oxervate eye drops for neurotrophic keratitis?
I'm not sure what that is. Oxervate?
Yeah, this is what they wrote. I don't know. What is it? Oxervate.
I'm not sure if it's lipoprotein E drop. I'm not sure. If that's the thing, it does have it. Some drops are being manufactured, which is ApoE lipoprotein drops. They contain the substance lipoprotein, which is responsible for the breakdown of the basement membrane in neurotrophic ulcers, and thus decrease the process of neurotrophic ulceration. If that is the drop he's talking about, so yes, it is one of the promising treatment options for neurotrophic keratitis.
One of the audience wrote that it is neurons growth factor. Neurons growth factor.
I'm not sure what it is. So if it contains substance P or one of the growth factors that are responsible also in the pathophysiology of neurotrophic keratitis, so yeah, I would consider giving the pathophysiology that it is due to the deficiency of such growth factors. And that's why we do the amniotic membrane, because it has a lot of growth factors in it, especially like insulin-like growth factor, substance P, lipoprotein E, procalcitonin. All these growth factors, they enhance the epithelialization. So if they can come up with a drop It's much easier than an emetic membrane.
Great. Last two questions. One is Avastin eye drops. Do you use Avastin eye drops?
Rare if ever, because I think the subconjunctival injection of the Avastin is doing quite a good job. Rare if ever I had to use it, unless I want to augment the effect of the Avastin subconjunctival injection, and I had extra, I just give it and let the patient use it until it's as an adjunct treatment until the next visit.
Okay, the last question is a patient with has renal failure on dialysis, and he has stromal herpetic keratitis. So what about the oral? You said that contraindicated the oral, right?
Yeah. Now, if he's in dialysis, I have no problem. But if he has kidney impairment, then that's the problem. So if he has kidney impairment, I would use the ointment to give me some window of using the stromal. If it's stromal keratitis with no epithelial defect, that's easy. I just use it twice a day, the ointment, and instill the drops. If he has a stromal necrotizing keratitis, which is a very bad condition, then I would want to use the oral. If he's already dialyzing, that solves the problem. If he's not, then I have to go to the just topical treatment.
Great, fantastic. Christopher, would you like to add?
Yeah, I think for each clinician in each country, each of us will have access to different medications and devices. So each person must work out their own algorithm, how to deal with, for example, a neurotrophic ulcer which refuses to heal. But I mean, I try and keep things simple, and I've hardly used any amniotic membrane. Of course, I mean, things like nerve growth factors, they're really great, they really do work, but they're so hard to get hold of and so expensive. I think mostly if we remove unnecessary medications and remove all the preservatives, and as a final kind of method, we can use a temporary central tassorrhaphy. I think that's really enough to deal with even the most severe situation. So that's one point. The other point is, again, sometimes I make myself unpopular. I try to keep my life simple and the patient's life simple as well. Herpetic disease is unilateral in the majority of cases, probably only 1% bilateral. So I think whilst they have one good eye, if the other one melts, then of course we have to do therapeutic surgery, either lamella or even sometimes full thickness, or a small one, a small graft, or even D-shape or banana graft, etc. However, if the other eye is seeing perfectly well and there is just a scar or lipid or whatever else irregularity, I tell them to keep that as a spare eye, because the prognosis is not good. And then you put in the first one, and very soon the second one, the third one even sooner, and it's a never-ending story. And then they become your friends or enemies. So I try and keep life simple for myself and my patients, and maybe sometimes make myself unpopular, because patients sometimes want to see with both eyes, and they cannot be convinced that one eye is better than one eye, and the other eye forever coming back to hospital. Thank you.
Thank you very much, Christopher, for the valuable input. Actually, Dr. Nancy, we would like to thank you very much for the informative lecture. And we would like to say that may Allah rest your father's soul in peace. And نسأل الله سبحانه وتعالى أن يجعله مع النبيين والصديقين والشهداء والصالحين وحسن أولئك رفيقا، وأن يجعل هذا العمل كله في ميزان حسناتك وحسنات إن شاء الله. And I would like to thank Prof. Leo for being with us. It's a great pleasure and honor. And of course, the journey has just begun. And of course, Professor Leo will give us an overview about the Wonderland before landing, of course. And this will be on the 2nd of May. We are eager to hear this overview lecture from him. Thank you, Christopher, for giving us some of your time, valuable time, and the same for Dr. Nancy for the comprehensive and informative lecture. I can see the feedback from the audience. It was fantastic, actually. Thank you very much, everybody. Thank you for the audience for attending and being with us. And see you then on the 2nd of May.
Thank you. Good night.
Thank you. Thank you. Good night.
Thank you,
Thank
Dr.
you.
Nancy.
Good night, everybody.
Thank you, Dr. Sinjab. Bye-bye.
Thank you. Goodbye.